Welcome everyone. Thank you so much for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital. Today's program is a special collaboration between the Blum Center and Department of Dermatology. Before we get started, I just wanted to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that everyone is in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical question or information in the chat box. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like you to help us complete. Your feedback is valuable to us as we plan future programs. Okay, so next I would like to introduce you all to Dr. Ramone Williams. Dr. Williams is a dual fellowship trained Mohs surgeon and cosmetic dermatologic surgeon. She is double board certified in dermatology and micrographic dermatologic surgery. Her clinical interests include micrographic surgery, facial reconstruction, cosmetic excisions, laser, Botox, dermal fillers, chemical peels, and skin of color dermatology. Professionally, Dr. Williams is a member of several associations, including the American Academy of Dermatology, the American College of Mohs Surgery, the American Society of Dermatologic Surgery, and the Skin of Color Society. In recognition of Skin Cancer Awareness Month, she joins us today to give a talk on skin cancer and sun safety. So please join me in welcoming Dr. Williams.
Thank you for that introduction, Amy. Hi, everyone. Thank you for having me. I'm excited to give today's talk. I'm going to go ahead and share my slides. All right, so today's topic will be skin cancer and sun safety. As you all may know, this month is Skin Cancer Awareness Month. So here I have a slide from the Skin Cancer Foundation. More people are diagnosed with skin cancer each year in the US than all cancers combined. So here I have an outline of today's talk. I'll give you a brief introduction on skin cancer, some definitions, as well as statistics on skin cancer. We'll talk about the most important and, the most common types of skin cancers. We'll talk about the warning signs of skin cancer treatments, skin cancer prevention, and lastly, we'll talk about sunscreen and sun safety. If you have questions, we'll have time at the end for questions. So as I go through slides today, we'll be covering quite a bit of information. So feel free to jot down your question and we'll be happy to address it at the end. So skin cancer is the most common type of skin cancer. The most common type of cancer. 1 in 5 Americans will develop skin cancer in their lifetime. The risk of skin cancer is much higher in patients with lighter skin, and we'll talk about what exactly that means. The average annual UV radiation correlates with the risk of skin cancer. Individuals who experience more UV radiation are at higher risk for skin cancer. So what does that mean? People who live closer to the equator experience higher UV radiation. Also, UV radiation may be cumulative. So sun exposure each day, each year, they all add up, and this will result in an increased risk of skin cancer. Now, we'll discuss a few types of skin cancer. Basal cell carcinoma is the most common type of skin cancer and one of the most common cancers overall. Squamous cell carcinoma is second in terms of incidence. Basal cell and squamous cell combined are considered non-melanoma skin cancer. Melanoma is much less common than basal cell and squamous cell. However, it's a much more serious skin cancer, which we'll talk about. So today's talk will focus on these 3 types of skin cancer. However, I wanted to make you aware that there are additional forms of skin cancer. These are considered rare tumors. For example, Merkel cell, DFSP. There are various other types of skin cancer that are beyond the scope of today's talk, but today we'll be focusing on the 3 most common skin cancers. So now on to basal cell carcinoma. So as I mentioned, basal cell carcinoma is the most common type of skin cancer. It commonly develops in people with lighter skin, and we'll talk about what exactly that skin phenotype is to have light skin and why that results in an increased risk. However, it's really important to note that basal cell carcinoma may also develop in people with skin of color, in people of all shades. They may look a little bit different depending on the shade of your skin, and I tried to include today a variety of photos to reflect that. So usually basal cell develops after many years of sun exposure. I diagnose basal cells all the time. I treat basal cells all the time. And patients will often come to me and they'll say, you know, but I never go in the sun. I never get sun. And I'll have to say, well, what about in your childhood? What about when you were a baby? All that sun exposure over time builds up and can lead to skin cancer later in life. The median age at diagnosis of basal cell is 68 years. However, we do see people younger and older with basal cell. It is possible to develop a basal cell at a very young age in teenage years or even in childhood, but typically these patients will have a genetic disorder or a genetic syndrome that results in being predisposed to skin cancer, and in particular being predisposed to basal cell. So basal cell carcinoma is associated with intermittent sun exposure. So for example, sun exposure for recreational purposes on and off over the years. And we'll compare this to the sun exposure that predisposes folks to squamous cell carcinoma. Another point I wanted to make is that basal cell as well as squamous cell carcinoma are associated with organ transplant. The reason being is that these patients have a depressed immune system and are immunosuppressed. So if you yourself have had an organ transplant, or if you have a loved one who's had a kidney transplant or a liver transplant, it's really important to know that there's a much higher risk of skin cancer, and it's going to be really important to be plugged in with your local dermatologist. Now, we've mentioned having lighter skin being a risk factor for skin cancer. What does that mean? In dermatology, we refer to skin types in order to accurately categorize and describe various shades of skin and various contents of melanin in the skin. So light skin is defined as skin that always burns, never tans. And I just wanted to take a moment to say that there's no such thing as a safe tan, but light skin by definition does not tan. Often these patients will have freckling, and then red hair is one of the most specific features of having light skin. In fact, patients with red hair are different on a cellular level, on a cellular and molecular level. The biology is actually different, receptors are different, and as a result, these patients have a higher susceptibility to skin cancer, developing skin cancer more frequently, and potentially having a less favorable course of skin cancer. So how to spot a basal cell carcinoma. In today's talk, for each of the 3 different types of skin cancer that we'll be discussing, I'll be showing clinical images. These images are from Visual DX, which is an online resource that's available to medical professionals and the public. And I tried to select cases that weren't the worst cases, but are actually more garden variety textbook cases in order for you to get a sense of what to look for on yourself or potentially on a loved one, to be able to say, hey, that looks a little bit suspicious. Maybe you should see your board certified dermatologist. So how to spot a basal cell. So here we have an enlarged view of a basal cell. For context, this is very zoomed in. In actuality, this is probably the size of the tip of a pencil, or it may be the size of a small pimple on the face. So a few things that I'm noticing with my trained eyes are, one, that this has a shiny quality. The light reflects more prominently off the center of this area compared to the surrounding skin, giving it a shiny hue. Another descriptor that's often used is pearly. Basal cells have a pearly look. They're a little bit translucent, a little bit shiny. So pearly is the classic term used to describe a basal cell. What we're also seeing in this image are blood vessels kind of on the periphery of this lesion. And blood vessels for me as a dermatologist are a red flag sign. Sometimes they're large enough for us to see with our naked eye. And at other times we have to use what's called a dermatoscope in the office, or a small magnifying glass or almost microscope, to be able to appreciate these blood vessels. So what about color? Basal cell is most often skin colored, so tan or beige, depending on the background color of your skin. However, they can also be pink. And in patients with skin of color, they may be brown or darkly pigmented. And in fact, there is a pigmented subtype of basal cell. So on the screen here, we have a pigmented basal cell carcinoma. Again, this image is from Visual DX. And at first glance, you may think that this is an age spot, a dark spot on the skin, but in fact, this is a basal cell on a patient with darker skin type. So here we have another image of a basal cell. I would say that this is a textbook image. If everyone hasn't appreciated exactly where the basal cell is, I'll give you a moment before I point it out with my mouse. But here, right on top of the ear, right where your glasses would sit, is the basal cell. So what am I noticing as a board certified dermatologist and board certified Mohs surgeon? I'm noticing that this is raised, this is shiny, and also right in the center, I can just see the outline of a blood vessel. So to me, those are all red flags that this could be a skin cancer, and it is a basal cell. Here's another image of a basal cell. Again, we're seeing some of the similar qualities that we saw in the previous slides. So right here, shiny, pearly, and again, a blood vessel coursing right through the middle, so red flag signs. So we've had two images back to back near the ears. The ears are a common site for basal cell, also the nose and the eyes. These are functionally and cosmetically sensitive areas, and they're also very common areas for skin cancer. So it goes without saying that early diagnosis and prompt management are really the key to success for these. So the progression of basal cells, why are basal cells harmful? On a big picture view, basal cells tend to be indolent or slow growing. However, they still can cause harm and can be destructive locally if they're left to grow unchecked. So we'll talk a little bit about what that means. So basal cells may grow in size. So here we have a schematic. The background here is background skin, and this orange color here is the basal cell, an illustration of the basal cell. So most commonly, basal cells may grow horizontally or in a radial growth phase. It may be slow, it may be by just a few millimeters, but as dermatologists, we know that even a millimeter of growth is significant. We have guidelines, specifically AUC criteria, appropriate use criteria, that tell us how we treat different skin cancers. And these are specific to a millimeter in size based on the type of skin cancer. So growth, even though it's slow, is quite significant. Basal cells may also grow in depth. So in contrast to the illustration and animation we saw on the previous slide, now we're talking about a vertical phase of growth. So here we have a schematic of a basal cell that's invading into the deeper layers of the skin. This can result in a higher morbidity or just a more difficult course after surgery. Basal cells may ulcerate, meaning the top layer of skin that was intact in the photos that I showed earlier, instead of being an intact, shiny papule, we're now seeing an ulcerated or an open sore. Clinically, this can be very problematic for patients. It can cause bleeding, soreness, local irritation, and of course, cosmetic disfigurement. Lastly, and most concerning, is that basal cells may grow and invade so deeply that they're involving adjacent structures, particularly nerves, blood vessels, underlying bone, cartilage, and muscle. And this is where they really become problematic. So again, prompt diagnosis and prompt treatment is going to be really important. So overall, metastasis in basal cell is quite rare. It occurs in every 1 to 1,000 to 1 to 35,000 cases, so exceedingly rare. And when metastasis does occur, typically it's associated with aggressive subtypes of basal cell that have been present for many, many years and have not undergone treatment. Now moving on to the second type of skin cancer that we will discuss today, which is squamous cell carcinoma. Squamous cell carcinoma is the second most common skin cancer. Squamous cells, or SCCs, tend to arise in a background of sun-damaged skin. They're associated with cumulative sun exposure. So this is in contrast to the intermittent sun exposure that was associated with basal cell carcinoma. Squamous cell is associated with cumulative sun exposure. So a little bit every day, a little bit every month, a little bit every year, all building up to increase a risk of skin cancer. Squamous cell is also associated with the HPV, or human papillomavirus. Classically, squamous cell can appear as a pink scaly patch. However, there are various morphologies of squamous cell. They can also be pigmented, just like basal cells, especially in patients with darker skin. And similar to basal cell, squamous cell is associated with organ transplant. So if you have a loved one who's had an organ transplant, or you yourself has had an organ transplant, it's going to be really important to have a trusted dermatologist that you're seeing to check your skin. There's a 65 times increased risk of squamous cell in patients who've had an organ transplant. So there are two subtypes of squamous cell that I wanted to talk about. So the first is squamous cell in situ, meaning that it's in the very top layer of the skin and has not gone past that top layer. And then there's invasive squamous cell, which is invading deeper in the skin and a little bit more harmful. So how do we spot a squamous cell? What are we looking for? So before we talk about squamous cell, I want to talk about a precursor lesion to a squamous cell. This is called an actinic keratosis, or a precancer. I see these all day long in the office, especially in the Boston area in our local community. We see a lot of patients who have lighter skin and who have experienced sun damage in their lifetime. And oftentimes they'll come in with these thin, pink rough patches. Sometimes they're very subtle and you can feel them more than you can see them. So I have another example here that's even more subtle. I'll point it out with my mouse in case you weren't able to see it, but here's one, here's another one, just these thin pink plaques that are on the skin, and they're rough to the touch. These are considered pre-malignant. If left untreated, they have the potential to transform into squamous cell over the years. These can be treated easily in the office. This is one example of an in-office treatment. This is called cryotherapy, or liquid nitrogen. We do this all the time as dermatologists. And it doesn't hurt too much. It's a little sting. And liquid nitrogen has the potential to destroy these premalignant cells and decrease that risk of transformation to an actual skin cancer over time. Here we have an image of a squamous cell. So as you can see, it looks similar to some of the images that we've seen before, but it's a little bit more impressive. It's a little thicker, it's more scaly, it's more well-defined. This may be mistaken for a rash or psoriasis, but this is in fact a squamous cell. So why is squamous cell harmful? So similar to basal cell, we went through step by step all the things that can happen with this basal cell: growth horizontally, growth vertically, involvement and destruction of underlying structures. All the same things can happen with a squamous cell. So most commonly, there's a risk of local destruction and disfigurement. However, squamous cell does have a higher risk of metastasis compared to basal cell. Metastasis means spread from the initial site on the skin to lymph nodes or other organs. However, it's very low, relatively low compared to other skin cancers at 4%. That being said, you really want to ensure that diagnosis is early and that there's prompt treatment to avoid having these aggressive subtypes spread to other parts of the body. The third and last type of skin cancer that we'll be discussing today is melanoma. So melanoma is the most serious type of skin cancer, and it has a higher tendency to spread or metastasize to other organs. So melanoma is less common than basal cell and squamous cell. As I mentioned earlier, basal cell and squamous cell are considered non-melanoma skin cancer, and melanoma is in a category of its own, partly due to its severe nature, and also melanoma is arising from cells that are pigment producing or from melanocytes. 20 Americans die each day from melanoma. In May, we observe Melanoma Monday, which is why this talk is quite timely. Melanoma can develop within a pre-existing mole. That's why for patients with multiple moles, it's really important to get your moles checked. We'll talk a little bit more about what to look for. What is it that makes a mole suspicious? However, melanoma can also appear de novo or just appear suddenly. This is actually the more common way that melanoma presents. It goes without saying, because of the serious nature of melanoma, that early diagnosis and treatment are crucial. So we'll talk a little bit about risk factors for melanoma. So melanoma shares a lot of the risk factors of basal cell and squamous cell, particularly lighter skin types, red hair, all confer a higher risk of melanoma. It's important to note that even one blistering sunburn during childhood can double a person's lifetime risk of melanoma. So that's just one sunburn in childhood. One bad burn can double your risk. Also, tanning beds. Tanning beds are really bad. As dermatologists, we cringe when we hear tanning beds. The use of a tanning bed before the age of 20 confers an increased risk of developing melanoma as high as a 47% increased risk. So avoid tanning beds. Also, with each session of tanning, that results in incremental increase in melanoma. So what are the stages of melanoma? So melanoma has various stages. The first stage, or actually stage 0, is melanoma in situ. So in general, melanoma in situ confers a very good prognosis. Typically, this means that the lesion was caught early and it's involving only that top layer of the skin. There's also invasive melanoma, and there are various stages, stage 1 through 4. The severity of melanoma is really determined by its thickness or its vertical depth. So this distance here from the top of the melanoma is actually measured, and we need to know how deep it's extending into the dermis or into the underlying skin. And that's what determines survival and prognosis. So here we have a graph from one of the key dermatology textbooks, Bologna, and this shows a comparison of survival curves for melanoma. So you can see that up here in stage 1 disease, this is disease that was caught early. It has a very good prognosis. And this is in comparison to stage 4, which has a much lower survival. In recent years, there have been really great breakthroughs in new therapeutics for melanoma. So I would say that overall survival for melanoma is improving compared to what it was a few decades ago. So how to spot a melanoma? Again, I wanted to include images here that weren't necessarily the worst cases, but are cases that you may encounter as a patient or as a loved one of a patient with melanoma. So here we have a patient with a brown streak on the nail. In this case, this is actually a little bit more advanced. We know that because the streak of pigment is quite broad. We're also noticing that there are different colors of brown. When I look at this nail, I see brown, I see black, I see reddish brown, and there are different colors and textures within the streak itself. Those are all red flag signs to me as a dermatologist. In this case, I would definitely recommend anyone with any pigment on the nail be checked by a board certified dermatologist. Nail melanoma, if caught early, is very treatable, but it can be quite aggressive. It may require even amputation of the digit. So again, early detection is quite important. Here we have another image of a melanoma. This is a patient's leg, and we see a small brown spot on the leg. At first glance, you may think that this is a mole, and we'll talk in a couple slides about what is it about this mole that makes, or what is it, excuse me, about this lesion that makes it suspicious, and that would signal to us, so maybe this isn't a garden variety mole and that this is a melanoma. If a patient walked in like this to my office, I would recommend a biopsy. What I'm seeing in this image, I'm seeing different colors of brown. I'm seeing dark brown, light brown. I'm noticing that the borders, the edges are not regular. They're a little bit irregular. And also this stands out. I'm seeing a background of relatively normal skin and in a very dark lesion that's standing out compared to the background skin. We have one last picture here of melanoma. I'll give everyone just a few seconds to take a look at the slide and see how you're doing with your visual diagnostic skills to see if you can point out the melanoma. So I'll just use my mouse here and point it out. Right over here is the lesion that's concerning for melanoma. So I show this image because many people have a back that looks like this, or you may have a loved one's back that looks like this, where there are lots of brown spots. In general, brown spots can be sunspots or lentigos. They can be nevi. This is a patient that has a combination of both. What we're looking for as a dermatologist is called the ugly duckling sign in a patient like this. We're looking for the dark spot that looks different from the others. So here we can see a lesion that has many different colors. It's larger in size compared to the other brown spots on the skin. And those are all red flag warnings that something isn't right and that this could be a deadly melanoma. So what are warning signs? So this is a schematic here, and centrally we have an image of a melanoma. And what we're noticing here are various colors. So here we can see very dark brown, lighter brown, a little bit of red brown, and some pigment, some blobs of pigment as well. So all these signs are telling me that this is an irregular lesion. And now we'll go through step by step. So the way that we like to think about melanoma and what to watch out for are the A, B, C, D, E's of melanoma. So A is for asymmetry. All these infographics can be found on the website of the American Academy of Dermatology. So I have it right there at the bottom of the slide, aad.org. So A is for asymmetry. So when we compare one side to the other, if we were to divide the image of the mole right down the center and compare one side to the other, they don't look the same. So that means that there is asymmetry, and I'm concerned as a provider. B is for border. A normal mole will typically have a circular border, an even symmetric border. And here we can see that this border is irregular, it's jagged. Again, that's our B, and that's another warning sign of melanoma. C is for color. The more colors we see, the more concerned we get. An average mole will typically consist of one even color. And in all the images that I've shown you of melanoma, we're seeing various colors of brown, sometimes dark brown, sometimes light brown. Occasionally, we can actually see what's called a halo effect, or actually lightening up the skin around a dark spot. That's also a red flag. It tells us that our body is trying to fight something off, particularly a melanoma, and it's not able to do that. So C is for color. D is for diameter. So the tip of a pencil eraser is around 6 millimeters, and that's a great rule of thumb of what size is relatively normal. Once a mole or skin lesion is expanding beyond 6 millimeters, or the tip of a pencil eraser, that really should send some red flags up and prompt us to see our board certified dermatologists. And lastly is E, evolving. How is this lesion changing over time? So when a patient comes to me in my office and they express concern about a particular lesion, I not only take note of what it looks like today in my office, but I may ask, what did it look like 6 months ago? What did it look like a year ago? And those are important clues as to whether or not this could be a benign mole or a life-threatening melanoma. And actually that change over time, that evolution, is quite important in my history. Patients may also complain of bleeding, itching, anything that just doesn't seem right. It's just better to have your dermatologist say, hey, this is fine, than just to sit and question at home. It's better to go in and get it checked and have a biopsy done if that's clinically indicated. So now we've reviewed the 3 major types of skin cancer, and I just wanted to give a general overview. What are signs of skin cancer? What are things that you at home should be aware of and keeping an eye out for? So the first is a changing mole. We went over that in detail just now with the A, B, C, D, E's of melanoma. A scaly patch, we talked about precancers and squamous cell carcinoma all can look like pink scaly patches. One that I really want to emphasize is a sore that doesn't heal. Cancer has always been described as the wound that never heals. That's a classic description of cancer. Similarly, for skin cancer, if there's something on your skin that isn't going away, that's a red flag. In general, our body does an excellent job and our immune system does an excellent job at getting rid of benign lesions. Our body can fight inflammation. Our body can fight minor issues. If your body's not able to get rid of something, if something's bleeding, coming and going, not going away, that's a red flag sign that it could be a skin cancer and should probably be biopsied. And lastly, a streak under the nail, which we showed an image of earlier. If you have a dark streak under the nail, or even at times a red streak under the nail can be a red flag, you should see your board certified dermatologist. So what do you do if you see a spot that you're concerned about? See your dermatologist. Why? Skin cancer always requires a biopsy diagnosis. Even if we look with our eyes and we say, this doesn't look good, it really involves the patient being on board, the patient giving us consent to do a biopsy in which we can confirm the diagnosis. A biopsy is also important in telling us what stage the skin cancer is at. Is it a superficial or early stage skin cancer, or is it a later stage skin cancer that may need more involved treatment? So now a few words on treatment options. So there are various treatment options for skin cancer. Most may be done in the office, right in the dermatologist's office. You may be referred to a dermatologic surgeon, such as myself, in order to have the appropriate treatment. So I'll just go through these various treatment modalities one by one. So the first is called electrodesiccation and curettage. This is a mouthful for what essentially is a scrape and burn. So essentially, if we detect a skin cancer early enough, then a very quick treatment can be done to essentially and effectively get rid of the skin cancer right there in the office where the skin cancer is scraped away and just lightly burn to get rid of those cancerous cells. An excision is when the skin cancer is removed surgically in the office and sent off to the lab. And we would get a report once it's sent to the lab on the margins. One of the most important things of treating a skin cancer is ensuring that we have clear margins or ensuring that there's no cancer left behind. Mohs surgery, I have a slide on coming up. So I'm a Mohs surgeon by training. Many people don't know what Mohs surgery is, but essentially it's a specialized surgery for skin cancer, which we'll talk more about. And it's just really the gold standard of skin cancer treatment. Lastly, radiation. Radiation is sometimes indicated for patients who are not surgical candidates or indicated based on the type of skin cancer. So now a few words on Mohs surgery. So Mohs surgery, or Mohs micrographic surgery, is named after Dr. Frederick Mohs. He pioneered the technique as a medical student and is very similar to the technique that we use today. Mohs surgery is the gold standard in skin cancer treatment. Mohs surgery offers the highest cure rate, up to a 98% cure rate. It's the most precise technique for addressing and treating skin cancer. It involves patient-centered care. Patients are involved in each step of Mohs surgery. You're awake the entire time and you're interacting with your surgeon. Mohs surgery also offers the best outcomes. It offers the most precision. It offers margin control. It gives you 100% certainty that there are no cancer cells left behind on the day of treatment. So here we have a schematic, again, from the AAD, just describing Mohs surgery. So in step one, we have a schematic of a tumor. And with Mohs surgery, a thin layer of the tumor is removed for each stage. So for stage 1, we would remove a thin layer around the visible tumor. The surgeon wears 2 hats as a surgeon and a pathologist. The tissue is examined under the microscope. Typically, the lab is right across the hall, and you're getting real-time results. Results can be available in as quickly as 1 hour, sometimes less than an hour. And what the Mohs surgeon is doing is that they're checking the edges and the depth of the skin cancer to make sure that that margin is free and that there's no skin cancer left behind. Oftentimes, skin cancer does not grow in an even plane. It may be invading the skin in an asymmetric way. You can think of just little tendrils or little roots invading into the skin. And it's really important that we capture and remove all of that in order for a good outcome. So in step 3 here, we can see just a tiny speck of brown right at the base of the surgical site. And this tells us that there is skin cancer that was left behind. So the surgeon would again repeat the steps initially and remove the layer of skin cancer. And this process would continue until clear margins are achieved. I wanted to just say a few words on the surgical repair. One of the reasons why it's really important to diagnose skin cancer early is to prevent the enlargement of that skin cancer and the growth in size. So based on surgical principles, in order to repair a skin cancer that has been removed, typically we would take an approach of a linear repair. Principles of surgery tell us that in order to do a linear repair, we actually have to create a fusiform design or an elliptical design, which is shown here. And the ellipse actually has to be 3 to 4 times the length of that initial lesion that was removed. So sometimes patients will come into the office with what seems like a very small skin cancer, but we find out that 1, under the microscope, the skin cancer is much larger than what we thought. It was just the tip of the iceberg. And 2, even once the true size of the skin cancer is known and removed, we have to then expand and elongate that area in order to close it in a cosmetically and functionally aesthetic way. And that can sometimes result in having a scar that's quite long compared to what you came in with. Another option for surgical repair are flaps and grafts. So here we have an image of a surgical flap. Most surgeons are trained in facial reconstruction. And here we can see that this patient presented with this surgical defect here, the size here of this pink circle. And in order to close it appropriately to maintain cosmesis and also to maintain function would be to do a flap. So you can see this patient would be leaving here with quite a long line of sutures. This image is from a textbook. This patient ended up healing beautifully. But just be aware, what seems like a very small problem can actually become a big problem and involve a complicated surgical repair. So again, prevention and early detection is key for skin cancer. So we're nearing the end of the talk. We're going to talk a little bit about prevention and sun safety. So prevention of skin cancer and sun safety go hand in hand. So here we have a few tips from the American Academy of Dermatology on how to prevent skin cancer and how to stay safe in the sun. So first, we recommend seeking shade. The sun's rays are the strongest between 10 a.m. and 2 p.m. Another tip that I tell my patients is that if you have an Apple Watch or an iPhone, they will often display what's called the UV index. If the UV index is low, that's a good time to go outside. In Boston, on cloudier days, and especially during the wintertime, the UV index may be 0, 1, or 2. As the UV index increases to 2, 3, 4, and it can go much higher, that's when the sun's UV rays are much more dangerous. If you don't have to be outside, don't go outside. And if you are outside, make sure you're outside and you're protecting yourself. So other ways to prevent skin cancer, wear sun protective clothing, such as long sleeve shirts with UPF and a wide brimmed hat. So many people don't realize you can actually get clothing with sun protective factor in it, with or UPF, which refers to, which is specific to clothing and hats that are meant to protect your skin from the sun. So there are various brands you can shop online. One brand that my patients like is called Coolibar, and they have many options to stay safe during the summer, and they're all light, breathable materials. So apply a broad spectrum sunscreen. So sunscreen is going to be extremely important in preventing skin cancer. I have a few slides dedicated to sunscreen, including how to select a sunscreen and how to apply sunscreen most effectively. So use caution near water, snow, and sand. The reason being water, snow, and sand all reflect UV rays. I'm sure everyone has gone outside on a cold, what seems like a cold Boston day where there's been snow, but it's almost blindingly bright. And that's because the snow is actually reflecting the sun's rays. So be very careful in these conditions. Avoid tanning and tanning beds. There's no such thing as a safe tan. There's no such thing as a base tan. Tanning is very dangerous. It doubles your risk of melanoma, and tanning beds confer a 47% increased risk of melanoma, as we talked about before. Regular skin exams are going to be really important. Find your local board certified dermatologist, start early, get your skin checked. So how to select a sunscreen. So sunscreen can be overwhelming. You walk into your local pharmacy, they'll likely have an entire aisle dedicated to sunscreen, and every sunscreen is different. Each has a different label, listing various things. How do you know what's important? So here we have an image of a brand of sunscreen, and I'm just going to walk you through what to look for. How do you read the label and what's important? So the first thing that's really important in sunscreen is making sure that the label says broad spectrum. Broad spectrum means that the sunscreen is protecting against both UVA and UVB rays. This is really, really important. As dermatologists and just as a member of the American Academy of Dermatology, we always recommend a broad spectrum sunscreen. The next thing to look at is the SPF. We recommend SPF 30 or higher as dermatologists. So oftentimes cosmetics, products that are facial moisturizers, they may say SPF 15. That doesn't cut it. SPF 20 does not cut it. It has to be 30 or higher. Once you're using a sunscreen that has an SPF of 30 or higher, there is some incremental benefit with higher numbers. For example, you may see 50, you may see 70. These are not 100% necessary because no SPF provides 100% protection. So as long as you're in that range of 30 or higher, usually 30, 40, or 50 are perfectly sufficient. So another ingredient that I tell patients to look for is zinc oxide or titanium dioxide. These are physical blockers, and we'll talk a little bit about physical versus chemical sunscreen. I would say that zinc is what you'll see most commonly in physical sunscreens, but this is really important. You really want to have a sunscreen with zinc. And lastly, water resistant. Water resistant means that the sunscreen is able to resist, in moderation, water from sweating and swimming. However, application is going to be, reapplication is going to be really important, but selecting an option that's water resistant will provide you a little bit more protection. So there are two broad categories of sunscreen, physical and chemical. Physical sunscreens work like a shield. They actually reflect harmful UV rays. You can think of a classic physical sunscreen as what the lifeguards used to wear, where they had the white just painted right across their face. Typically, physical sunscreens contain zinc oxide or titanium dioxide. Some contain both. Today, there are many formulations that are branded as invisible or translucent. And in general, physical sunscreens are a little bit safer for people with sensitive skin. Chemical sunscreens are also safe and effective. Chemical sunscreens work like sponges. They absorb UV rays in contrast to physical sunscreens that reflect UV rays. There are various types of physical sunscreen. You may see various ingredients, oxybenzone, avobenzones. In general, chemical sunscreens are easier to blend with various skin types. If you have a warmer skin type, it may be challenging to blend zinc oxide or titanium dioxide into your skin. However, you should consider a tinted sunscreen. We found actually that tinted sunscreens, recent studies show that the tint actually helps protect against visible light, which we now know contributes to some disorders like melasma, dark spots, and hyperpigmentation of the face. So in general, I recommend a tinted sunscreen. Tips for sunscreen application. And we're nearing the end of the talk, so if you have questions, please start putting them in the chat so that we can get to your questions and address any questions that you have today. So applying sunscreen correctly is going to be just as important as selecting, if not more important, as selecting the correct sunscreen, because we need to make sure that the sunscreen that you've applied will work in an effective way, and that depends on appropriate application. So apply sunscreen 15 to 30 minutes before going outdoors. This is important because it takes sunscreen about 15 minutes to absorb. So just work that into your morning routine, work that into getting ready, and try to get that sunscreen on 15 minutes before your sun exposure. Most adults need 1 ounce to fully cover the body. 1 ounce is about the size of a shot glass. So keep that in mind on your vacations coming up this summer, that you really need 1 ounce or a shot glass worth of sunscreen in order to be protected. Apply sunscreen to all bare and exposed skin. Don't forget areas like the lip. They have lip balm containing sunscreen. And also don't forget your scalp, especially if you have thinning hair or men who have bald scalps. A hat is going to be really important. Also, they have spray sunscreens that are meant for the scalp. Reapply sunscreen every 2 hours after swimming or after sweating. So thank you for your attention today. I'm just going to summarize everything that we've gone through. So skin cancer is the most common skin cancer in the US. There are 3 common types of skin cancer: basal cell, squamous cell, and melanoma. Of those 3, melanoma is the most serious type of skin cancer. Sun safety and skin cancer prevention go hand in hand, so please try to remember the tips for sun safety that we discussed today and work them into your routine. And lastly, and most importantly, if you have a suspicious spot on your skin or if you're high risk, please see a board certified dermatologist and get your skin checked. Thank you for your time. These are my references. Now we'll go to questions.
Thank you so much, Dr. Williams. We are now at the end of the session, so if you have any questions for Dr. Williams, feel free to enter them in the chat. So we have a question on UPF clothing. Do they need to be treated in a certain way when washing them?
Great question. So it depends on the brand. Typically, the UPF is actually intrinsic to the material itself, so you don't have to worry too much about washing off, like for example, something that the material was treated with. Typically, they're using a material that has inherent properties to keep you safe from the sun. And I would just follow the manufacturer's recommendation for washing, but in general, gentle washing is safe. Washing on a cold cycle, washing on a gentle cycle.
Thank you. We have a question about sunscreens. Do you have any thoughts on the benzene contamination in some sunscreens? Would you use the physical sunscreens? Would use of the physical sunscreens be better instead of the chemical sunscreens?
So that's a great question. That has been a hot topic. A while ago, there was an article that came out in several different media outlets about sunscreens that were potentially contaminated with benzene. So of course, this caused quite a bit of concern among the public. In general, and according to the formal statement of the American Academy of Dermatology, chemical sunscreens are safe. And I think that we're in a day and age where the word chemical sounds scary, but chemical is really, everything that we use is chemical. A chemical is something with a physical property. And that means that they're active ingredients, and it's really hard to avoid them. I personally tend to use physical sunscreens. One, because I have sensitive skin. Sometimes you'll have sunscreens that are a combination of both. What I look for in sunscreens in particular is that zinc oxide or titanium dioxide. So by default, that is putting you in the physical sunscreen category. However, it's not always black and white. Sometimes there are sunscreens that have zinc oxide and titanium dioxide, which are considered physical, but they may have a chemical component as well. So how do you choose what's best for you? One, I would say it's better to have a sunscreen with zinc or titanium. They're a little bit more effective in giving you that broad spectrum coverage. If you have a known sensitivity to a chemical such as avobenzone or oxybenzone that's in the sunscreen, of course, stay away from those, but one is not necessarily bad. In terms of the specific question about benzene contamination, those manufacturers did release a list of the specific products and dates in which there were concerns. So of course, check your products and make sure they were not one of those specific products on the list. If they were, discard those would not be safe to use. But in general, both categories of sunscreen are safe.
Thank you. Do sunscreens expire?
Yes, great question. Sunscreens do expire, unfortunately. So typically there is an expiration date. Sometimes you have to flip the bottle over and look at the bottom. Sometimes it may be close to the cap or hidden in there, but there is almost always an expiration date. I think that it's prudent to look at these expiration dates. Sometimes you're in a bind where all you have, if that's all you have and you're at the beach, use it. But in general, try to plan ahead, check your sunscreen beforehand. Honestly, check even when you're at the store. The manufacturer should be checking these, but check when you're at the store. And not only with sunscreen, but with a lot of topicals that we use in dermatology, they're sensitive to heat and they're sensitive to light. So try not to keep sunscreen in a hot car. Don't keep sunscreen in an area where it's going to be getting a lot of direct sunlight or heat. That can really affect the integrity of that product. And that goes for many of the topicals that you may use in your skincare routine, but always check the expiration date. That's a great question.
Thank you. For sunscreens that haven't expired yet, are there things to look for to ensure that they still work well?
Yep, great question. So I would say when you open a brand new bottle of sunscreen, pay attention to the color. Usually it'll be a white color. If it's a tinted sunscreen, it may have a little bit of a brown tint. One red flag with a sunscreen that is expired or isn't quite right is that it may feel like it's coming out of solution. It may be a little bit more watery or the color might change. That would be a red flag. Do not use that sunscreen and just go ahead and buy a new bottle.
Thank you. And you had covered some sunscreens earlier. What are some examples that your patients like to use for sensitive skin?
Yeah, absolutely. That's a great question. I get a lot of, requests for sensitive skin sunscreen. So I'll just give you general examples of different brands that my patients like. Neutrogena is one brand. Neutrogena has brands that are targeted for sensitive skin. So you'll see Neutrogena Sensitive or Neutrogena Pure Zinc. Another brand is Cetaphil. Cetaphil in general is a brand that is geared towards sensitive skin, and they make sunscreen. Some of their facial moisturizers have sunscreen in them, but they also have dedicated sunscreen products. And typically these will be marked for sensitive skin. The last product that I like is called Elta MD. This is not sold in stores, but it is available online. And again, they have specific lines that are targeted for sensitive skin. I would say if you have very sensitive skin, you should be working with a dermatologist to find out why your skin is sensitive or to see if you can determine what your skin is reacting to, and do a test spot first. If you buy a brand new sunscreen and you have a big trip coming up, maybe buy a few brands, test it on an area, you know, just like a small area on your wrist or on the back of your hand, see how you react to it before using it on the entire face.
Thank you. You had reviewed tinted moisturizer with sunscreen earlier. How about liquid foundation with sunscreen? What are your thoughts on that?
Yeah, great question. I have found that it's very challenging to find a liquid foundation with sufficient SPF numbers. Almost always, and one website that's good to kind of figure this out is, are actually some of the websites for these cosmetics. For example, Sephora allows you to search not only by the SPF factor, but also by active ingredients. Most of your liquid foundations are actually only going to be SPF 15, which is not sufficient according to the American Academy of Dermatology, and they may not contain zinc oxide or titanium dioxide. So if you can find a liquid sunscreen that has SPF 30 or higher and contains zinc or titanium, I would say go for it. But I would say in my experience, they are few and far between, and it's probably going to be better for you to put your sunscreen on as your first layer underneath, and then to layer your liquid foundation on top of your sunscreen.
Thank you. So while we wait to see if there are any additional questions for you, do you have any final thoughts you'd like to share with the audience?
Yeah, I will say that, you know, skin cancer affects everyone. I see patients of all ages. I see young adults who are just starting their life, and I see older patients in the prime of their lives as well. So skin cancer doesn't discriminate. It affects patients of all ages, all skin tones, all ethnic backgrounds. So just please try to be safe, practice sun safety, and see your board certified dermatologist.
Thank you so much, Dr. Williams. I don't see any additional questions, so I think we can end today's session. As I had mentioned, today's session is being recorded, so if you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.
Thank you. Thank you for having me. Thank you, Amy.